In survivors of sudden cardiac death, coronary artery disease is the most common underlying etiology, identified in approximately 70 to 80% of cases. Consequently, coronary angiography and revascularization are central to the diagnostic and therapeutic pathway. Current guidelines emphasize that the timing and necessity of these interventions are heavily dictated by the presence of ST segment elevation and hemodynamic stability. Angiography serves both a diagnostic role, that is in identifying the culprit lesion, and a prognostic role for assessing the extent of coronary artery disease. Immediate angiography within 2 hours can be considered in STEMI on post-ROSC ECG, that is on return of spontaneous circulation. ECG shows ST elevation. That is a strong predictor of acute coronary occlusion requiring immediate coronary angiography as a class 1 recommendation. Hemodynamic instability. Even without ST elevation, patients in cardiogenic shock or with life-threatening arrhythmias like an electrical storm should undergo immediate invasive assessment. Delayed or selective angiography. Non-STEMI and STEMI patients. For stable survivors without ST elevation, recent randomized trials like QUACT and TOMAHAWK have shown that immediate angiography does not improve survival or neurological outcomes compared to a delayed approach. Pre-discharge recommendations. Guidelines recommend coronary angiography before hospital discharge for all cardiac arrest survivors with a suspected cardiac etiology, particularly those with a shockable rhythm or unexplained left ventricular dysfunction. Revascularization with percutaneous coronary intervention or coronary artery bypass grafting aims to stabilize the myocardium, prevent recurrent arrhythmias, and preserve left ventricular function. Acute benefit. In the setting of an acute coronary syndrome, prompt revascularization reduces the risk of reinfarction and improves post-resuscitation hemodynamics. Arrhythmia suppression. Revascularization can eliminate the trigger, like ischemia, for ventricular fibrillation. However, it may not address the substrate, that is an old scar or fibrosis, meaning an ICD is often still required for secondary prevention. Left ventricular recovery. Successful reperfusion can reverse myocardial hibernation or stunning, potentially improving the ejection fraction over the following 3 months. Here are the key considerations for the clinical team. Post-ROSC STEMI, that is after recovery of spontaneous circulation, ECG showing ST elevation myocardial function. Emergency PCI. High probability of acute occlusion, time-sensitive survival benefit is there. Post-ROSC and STEMI, which is stable, delayed angiography, allows for neurological assessment and stabilization. No benefit found for emergency timing. Complex multi-vessel coronary artery disease needs heart team discussion to decide between percutaneous coronary intervention and coronary artery bypass grafting based on syntax score and patient frailty. Severe left ventricular dysfunction. Re-evaluate ejection fraction at 90 days. Revascularization may improve ejection fraction. ICD eligibility is usually reassessed after a waiting period. Limitations and caveats. Neurological status. In comatose survivors, the decision to proceed with invasive intervention must be balanced against the perceived neurological prognosis, which is often difficult to determine in the first 72 hours. The no reflow phenomenon. Post-cardiac arrest syndrome involves systemic inflammation and microvascular dysfunction, which can sometimes complicate the success of percutaneous coronary intervention. In survivors of sudden cardiac death who have a prior myocardial infarction but preserved or mildly reduced ejection fraction with left ventricular ejection fraction more than or equal to 40%, the role of revascularization is primarily focused on eliminating ischemia as a trigger for recurrent ventricular arrhythmias. Revascularization for secondary prevention. The core principle is that if the SCD event was clearly triggered by an acute ischemic event, like a new myocardial infarction, revascularization is the primary treatment. However, if the event was due to an old scar, that is a substrate, the recommendation changes. Class 1 strong recommendation for revascularization in survivors of SCD who have significant coronary artery stenosis and evidence of ongoing or acute ischemia that is suspected to have triggered the arrhythmia. Class 1 strong indication in patients with a prior myocardial infarction and preserved ejection fraction who present with hemodynamically unstable ventricular tachycardia or ventricular fibrillation in the setting of an acute coronary syndrome. Prompt revascularization is required. ICD versus revascularization in preserved ejection fraction. This is the gray area for many clinicians because most ICD trials like MADIT2 or SCD-HEFT focused on low ejection fraction, less than or equal to 35%. Class 1 for secondary prevention, an ICD is recommended for survivors of SCD due to ventricular fibrillation or hemodynamically unstable VT that is not due to reversible cause such as an acute ischemia within 48 hours of an MI. If the SCD occurred and you find an old scar with significant stenosis but no acute occlusion, revascularization alone is often considered insufficient. The ICD remains a class 1 recommendation regardless of the ejection fraction. Class 2A moderate. In patients with a prior myocardial infarction and preserved ejection fraction who have sustained monomorphic VT that is hemodynamically well tolerated, catheter ablation or revascularization if ischemia is present is reasonable, often in conjunction with or as an alternative to an ICD. Here is a summary of potential value of revascularization. SCD with acute MI, STEMI or NSTEMI, class 1. Revascularization treats the acute trigger. SCD plus chronic CAD, no acute ischemia, class 1 for ICD. Revascularization may be done but does not replace the need for an ICD, that is, the substrate remains. SCD plus coronary vasospasm, class 2A, ICD should be considered even if revascularization or medical therapy is performed. It is critical to distinguish if the SCD occurred within the first 48 hours of an acute MI. If revascularization is performed and the arrhythmia occurred during the acute phase, it is considered reversible and an ICD is generally not indicated. If the arrhythmia occurs after the first 48 hours, even with preserved ejection fraction, the risk of recurrence is high enough to warrant an ICD.